Thank you for joining the first session of our new COCR ValuePath mini webinar series. It's a privilege to have you join us. Our topic today is alignment and clinical integration. Hopefully you got a chance to pre-submit your questions, but if not, you can submit your questions to me via email at sburnett, B as in boy, URNETT @cokrgroup.com after the presentation, and we will answer your questions then. If you have questions related to future topics in this series, please be sure to submit your questions to me prior to those sessions. After today's presentation, if you would like more information on the topics discussed and how they affect your organization specifically, please reach out to me directly and we'll coordinate a time for you to speak with one of our associates. The participant phone line will be muted for today's presentation, and the material will be emailed to you shortly after the conclusion of the session. The slides are also available to download as a handout in the GoToMeeting dashboard. Finally, as you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation. Today's discussion will be led by Max Reibel, President and CEO of COCR, and Amy Greeter, Senior Vice President. Please join me in welcoming Max and Amy.
Thanks, Savannah. This is Max, and we appreciate this time that you've given us to share these thoughts with you in our COCR ValuePath mini webinar series. As Savannah indicated, our subject today is specific to alignment and clinical integration, and Amy and I will share a few thoughts with you over the next 30 minutes and also take some questions that were turned in, as Savannah said, prior to the commencement of this presentation. Today our agenda, and I'm on slide 2, is to really look at the impact of the MACRA and MIPS legislation on provider strategies. Amy's going to really tackle that one, and also some thoughts on alignment and integration models. I'll look at some of the the legal ramifications, and wind up our brief presentation through a discussion of some of the basic overarching obstacles and the cost of clinical integration and forming those networks. So I know we have a lot to cover in a short amount of time. Let's get right to it, and Amy, if you'll share with us some thoughts relative to the first section.
Sure, sounds great. Thanks, Max, and thanks, Savannah, for getting us kicked off today. I am delighted to be speaking with y'all today, and certainly I'm excited to talk about the narrow focus of alignment and integration that we have proposed for this session today. I know that COCR has, as the folks before me have said, a series, but I'm really delighted to talk with you about alignment and clinical integration because I think that it answers a lot of questions that we are asked by current and prospective clients about how they respond to MACRA. So just by way of overview, most of you know this by now, but MACRA was enacted in April of 2015, and it was meant to really shake up the healthcare landscape to be a replacement for what many saw as a flawed sustainable growth rate, or SGR formula, that had previously been a way by which physicians were paid. And the SGR formula had been one that had been kicked down the road for several years now, and no one really knew how to tackle. And so MACRA came in as a way to replace the SGR and provide a new quality payment program as a basis for physician compensation. MACRA was passed in 2015, but the proposed rule didn't come out until the end of April 2016, and we are anticipating that the final rule will come out in November of this year. The performance period will begin January of 2017. So there's not a lot of time between the passing of MACRA to its proposed rule to its final rule to the performance period. So now is a great time for you to be listening into things like this to really understand what it includes and how do you begin to prepare. So MACRA broadly is creating a proposed framework for quality payment that includes two paths. One is a merit-based incentive payment system, or MIPS, and one is the Advanced Alternative Payment Models, or APM. And so what MACRA does is it has these two paths for which physicians can receive payment going forward. And it's meant to be a path that allows you to take one or the other and move between the two as you develop expertise, as you progress in terms of your structural development. But those are the two tracks that people can follow. MACRA really encompasses a lot of things beyond the SGR or replacing the SGR. It takes into account existing reporting and payment programs like PQRS, like the VPM, and like the Meaningful Use programs, many of which we are all familiar with. So think of MACRA as a really sweeping change. As I noted before, the performance year will start, at least as we anticipate it now, January 1st of 2017, with there being 2 years of data collection that will ultimately impact what payments come out starting in 2019. So think of 2017 and 2018 not as your practice years, but as actual years that will impact your go-forward payments. So it really is important that, again, you familiarize yourself with MACRA and its tenets now and start to make adjustments now so that you can be successful and maximize your economics under MACRA starting in 2019. Let's talk a little bit about these alignment and integration models and how do they tie into MACRA and what it's calling for. So one of the things, and Max and I were actually on a call today talking with a group of leaders from the hospital about alignment and integration. And what we were telling them was there really is sometimes a difference, while people may not recognize it, between alignment and integration. Alignment can be a very structural model, and integration is the next step, the stage 2 of that alignment. It's where the bonds are made from a cultural, clinical, legal, financial basis. And so as you think about the higher order of progression and that which will be required to be maximally successful under MACRA, it's really moving toward that integration level that will put you in the best spot to succeed. And so there are a number of models that are preferential for people to consider moving towards now to ensure they are maximally successful under MACRA. These are listed here on slide 6. Things like ACOs, CINs, quality collaboratives, and patient-centered medical homes. And so we'll talk a little bit about each of these. ACOs, as many of you know, are a very popular model. They have been in existence for some time, but were really made more widely popular as a result of the Medicare Pioneer Model ACO and the Shared Savings Program. So when we talk about ACOs, we often refer to some of the existent programs that are in place for our governmental payers. The contrast to that is a clinically integrated network or a clinically integrated organization, as it may be called, which is looking at the same things that are considered under an ACO, but more focused on our commercial payer patient populations. So instead of our governmental payers, it's just the other side of the fence looking at the commercial payers. Quality collaboratives are focused, as you would guess, on the quality aspect of things. CINs and ACOs are inherently quality collaboratives, but quality collaboratives sometimes have a different focus without all of the various metrics that are included in ACOs or CINs. So you may find that there is a more narrow focus rather than a broad focus in a quality collaborative model as opposed to what you would see in an ACO or a CIN. The final model is the patient-centered medical home or the medical neighborhood model, which really takes a look at providing primary care services to a patient and allowing that patient to be really encapsulated in a very total health-based population model. There are specialty-specific medical model homes that exist. Obviously, there is an existent oncologic program that has been endorsed by the government right now. And so there are definitely specialty-specific medical homes as well. Now, one of the things that we have been asked or are often asked by our clients is, okay, what should I do now? You know, macros come out, I feel a sense of urgency to do something, but I'm not entirely certain what should I do. I don't know what my organization personally needs to do to be successful. And the questions that we get are often, you know, is now the time, if we're a private group, to align with our either local or regional or even national health system? Should we be looking for a partner? Or if you're a hospital, some of our clients ask, okay, does this mean that we have to employ everybody right now? You know, do we have to snatch everyone up, all of our physicians up? Because while macro doesn't apply to hospital payments, it certainly applies to physician payments. And there could be some advantage to us growing a network of providers in that manner. And so what we've tried to do here on slide 7 is give you an example of what is the best model for your organization. And I am 9 months pregnant right now, due on Monday. So I told the staff that was working on this presentation to look at it like a swimsuit chart. You know, if your body type is this is the best swimsuit for you. Maybe in dreaming that a swimsuit is in my future, in the near future. But if your body type, for example, is a hospital or health system, or even the employed physician network of a health system, and you have a great deal of Medicare and Medicaid patients, then we say the best swimsuit for you, the best option for you, is to go towards pursuing an ACO model. And everyone knows that there is a fair amount of rigidity in the Medicare ACO program right now, but that can be a great thing. That rigidity can give some very specific structural and operational guidance to organizations that maybe are bereft right now of some direction. So if you have a high Medicare or Medicaid population, think about ACO as being the best strategy for you to consider. Secondly, if you are a multi-specialty group or a health system that has a heavy commercial payer mix, think about pursuing the clinically integrated network option. Again, the alternative to ACO, really focused on commercial payers. Number 3, if you're a private group or you're a hospital that has a consortium of independent entities that either you're a part of or comprise your total healthcare delivery system, think about going the quality collaborative route. And that may be things focusing on, for example, upside-only risk-based contracts, depending on quality outcomes. It could be some sort of shared savings based on quality, but it can be a very specific focus. As you may or may not know, in the MIPS system, 50% of the total score in year 1 is based on quality. So there is a huge focus on quality. And then finally, if you're a large primary care group or a multi-specialty group that has a steady primary care base, or you're one of the applicable specialty groups, as I alluded to earlier, such as oncology that has a very specific patient-centered medical home, then that's likely the direction you should be heading. So while there are variants in all of these models, there are some natural paths that I think are developing for different types of organizations that should be considered now. I will tell you that in any of these models, there are certainly very stringent compliance regulations that need to be considered. And I'm going to have Max move on to slide 9 to talk to you a little bit about what happens regardless of model when you're looking to strive to achieve clinical integration. So Max?
Okay, thanks Amy, and I appreciate those insightful comments. Yes, indeed, compliance is alive and well in this setting, as I'm sure we are not the least bit surprised about. So when forming a clinically integrated organization, a lot of the same legal scrutiny over those transactions will exist as what we're familiar with in what we call the first stage of alignment integration, which is employment or professional services agreement, etc. And as such, we have to really build in safeguards and a very, very good documentation system to make sure that the funding, the evidence-based medicine documentation, and really the guidelines for participation in this organization are fully adhered to. Many IPAs, as you know, and PHOs are looking to become clinically integrated, frankly, even to become clinically integrated prior to the advent of MACRA and value-based reimbursement in a fee-for-service environment. In order to negotiate fee-for-service contracts, they must be clinically integrated. The same principle holds for a value-based clinically integrated network, and so we have to have consistency in participation, adherence to guidelines, and the overall governance processes. And we certainly have to have a level of fair market value when it relates to distribution of funding and investments of monies going into CINs. So all of these things are in play. This session is not about to drill down on specifics relative to the legal compliance other than to heighten your awareness. As is always seemingly the case, we have to be reminded that these things are clearly in play here. Now, with that having been said, I am on slide 9, and the last bullet I think is relevant. And within the CINs that at least we've had the experience of forming, and this is generally the case at this juncture, is that the participants are allowed the freedom to contract independent of the payer contracts in the CINs. It's not a closed shop. That may change. I'm not necessarily saying that's a legal matter that it will change, but for the moment, that freedom exists. So if you're a part of a ACO, commercial ACO in particular, or CIN as we refer to them, that could well be an option and maybe a viable one, particularly when the CINs are still in the formative stages. Let's move on to slide 11, and I want to talk a few minutes about some of the risks and challenges that are systemic to this entire process. There are a lot of things out there that need to be considered before you endeavor into such an entity. We have the opportunity to work with major health systems, community hospitals, really runs the gamut, as well as private groups. And we're often asked that question in this day, at this point in time, and that is, why? Why do we need to do this? It's not upon us yet. I think MACRA really changed the game a great deal. When MACRA was passed, not a heck of a lot was said about it, but I can assure you, as it's gotten closer to the requirements that Amy alluded to early on in this presentation, it's becoming much more relevant. And as such, we're seeing much more interest in ACOs and CIN initiatives. So the federal government is likewise pushing for these things, and we have to be open and objective in our assessment when we're looking to put these together, that there's a cost tied to it. There's the question of, well, deployment is not imminent, so why do it? That's often the thing that we get is, let's move slow, the sky's not falling, etc., on us, and therefore it should be a deliberate approach. Quite frankly, depending on where you are and what the market is, that's probably not a bad strategy. But doing nothing is not an option either, because there is a competitive edge, I'm on slide 12 now, that really must be considered when you're forming your clinically integrated organization, the reasons for doing so. We feel that with MACRA firmly in place, and there's been some discussion that MACRA may be deferred, but only for about 6 months, not a long time, that these things are going to have to be addressed, and we believe that a clinically integrated organization or clinically integrated network is indeed the best format to do it. We think that the metric for success under a value-based paradigm will be how well you can form your organization and demonstrate high quality and cost-effective care, certainly, as we might say, efficient care. And so it will really be incumbent upon each provider organization to assess how best to do this. And once again, we feel that a CIN is that best mode. What's it going to cost? That's always a question that we are asked. And capitalization of these entities is a real wild card. I alluded to the fact, or to the statement a moment ago, that we're seeing a lot of IPAs and PHOs, I call them, morph into CINs, and indeed that is a good strategy in our opinion, and often will save a few bucks. There are some PHOs or IPAs that have some reserves, so that may be a source of capital to fund the needs to put together and formulate and be in compliance with the things that we talked about a few minutes ago under the legal compliance requirements. What will it cost? Well, we've tried, and believe me, this is a real estimate, I would say, of a range, but if you have some infrastructure in place, if you have some interoperability already existent, then there's a good chance that you can save, and at least the initial formation cost could be relatively low, perhaps under $100,000 for legal, consulting, etc. On the other hand, to build from the ground up could easily cost $500,000 and perhaps more depending upon the size. I always say before you do anything, complete a business plan or strategic plan, whatever you want to call it. Do a fairly detailed pro forma and really budget on the high side for your cost, and then at best case you're probably going to come in under that, and at least you didn't overextend yourself. There are ways to finance this, and many interested parties are out there to do that, banks and what have you. There are challenges in this process as I look at slide 13 and 14, and we'll wrap this session up and go for your questions. There certainly are questions, well, how will our income be realized? This is a new paradigm. What are the governance and management structures in this NewCo, as it were? And how do we really navigate through this whole fee-for-value structure as opposed to what we've been used to for all these years? We're so accustomed to fee-for-service, fee-for-volume. These are all things that will need to be addressed. Clinically integrated organizations, by definition, are not usually entities where you're all under a single legal entity to begin with. In other words, you're all part of a single provider number. You typically are from disparate systems, and you remain certainly to a certain extent in that way in your day-to-day operations and legal identification. You've come together in a CIN in only that manner. So it is a real adjustment, and it's going to require a new way of thinking. It'll require different methodologies, longer payback periods, additional risk in that risk supporting mechanisms, actuarial projections, claims tracking, claims analysis. Some of that we already do, but really not in the context of stratifying our utilization and our resource allocations. There may in fact be, depending on if whether or not you're capitated and taking on more risk, even reinsurance that would be required. So I use the term, what we're going into is a new world order, and maybe that's a bit overstated, but at least in our healthcare industry and what we're about to embark upon, I believe it has an element of truth. The last few slides that we're going to just draw your attention to is a process, and we call it Coker ValuePath. And essentially what it boils down to is an approach that through our research, through our own education and experiences, that we believe might make some sense for really those who have not endeavored in a big way into this whole clinically integrated process. And so again, we have tried to lay out for you, particularly on the first slide under this section, the methodologies for moving from volume to value and the things that need to be thought about in that context. And then we've given you more flavor in the few slides that follow. So with that stated, Amy, I think we're about ready for a couple of questions and we'll finish it up. Savannah?
Sounds great. So we have been able to incorporate some of the questions that we received in advance of the session, but there were a couple that we got to that we hadn't yet had a chance to address. So let's talk a little bit about some of those. So the first one is, and this is actually a very good one that we hear a lot of, is our market is still fee-for-service with minimal value-based programs in place. How do we prepare for MACRA and MIPS? Is it important that we change our ways now? And so, again, this is a great question, and the reality is that many of the markets that we work in, if not most of them, still have the majority of their reimbursement tied to fee-for-service, as opposed to something that's value-based. And we actually, at Coker, I think our collective belief is that fee-for-service is never going to go excuse me, away totally. And so as you think about the future, we don't recommend that you think about reimbursements ever being totally based on some risk-based model. There'll always be some component of fee-for-service. So what we've been advising people to do is think about how do you prepare, how do you transition over a 1 to 2 year timeline and then a 3 to 5 year time frame. So bring those two as sort of separate timelines and prioritize what you need to get done in those two sections. And when you're doing that, you need to think about some things. So, for example, do you have an accountable care era strategy in place at all? Do you, have relationships with your local providers, whether that's other hospitals or physicians or other medical groups if you're a private practice, in any way that move you towards preparation for value-based incentives? Or are you right now at a point where you have operational gaps that won't allow you to be successful as you transition away in some part from fee-for-service? All of those things I think need to be considered right now and need to be prioritized, again, on a 1 to 2 and then a 3 to 5 year horizon so that you can start preparing. I think one of the things that we have been asked is, what can Coker do to help us develop and support our strategy? What are Coker's services? So you saw Max and I referred to the Coker ValuePath assessment in the preceding slides, and certainly we welcome you to get more information about that. But I think having some sort of assessment, whether it's done by a third party or it's done by your independent resources, is important at the outset of this process. I just talked about having that strategy that you develop, but really starting with an assessment is critical so you know where you stand and then can build the strategy upon that. I will say that it's likely very important that you engage counsel, legal counsel, earlier than later in this process. We obviously are not legal counsel, but we work with a lot of great attorneys, and I will tell you that having them involved in this process early on also makes a big difference in being able to provide you with guidance both from the structural aspects as well as all of the various regulatory aspects. There are federal laws, there are state laws, there are very specific business laws that you need to think about in terms of your organization and where you're going. So those are important too. I know that we're likely running out of time, so let me turn it back in our last few seconds to Savannah and ask Savannah anything we need to do to close out today's session.
No, I will just remind everyone that if you have further questions regarding the things we talked about today, you can reach out to me directly, and I will coordinate getting those answers to you from our team. Again, we would greatly appreciate your feedback on this presentation through the survey as you exit the webinar. The slides to this presentation will be emailed you tomorrow along with a recording of the presentation. Thank you, and we look forward to having you join us on the future sessions in this series. Thank you.